So I'm Dr. Chewe Luo. I'm the Associate Director of the HIV Program at UNICEF in New York, and my co-chair...
Annette Sohn from Treat Asia in Thailand.
Right, so this session is just 1 hour. It's really a poster presentation. Each of the speakers have been told to speak for 5 minutes. We just want you to get a sound bite of the work they've been doing. We don't have time to have a question and answer session at the end of each presentation, so you bear with us that we're going to ask each one of the presenters to speak for 5 minutes, and then we'll have time for discussion at the end. Okay? So start with our first speaker, and this is Luana Hatane, who's the Executive Director of PATA, and they'll be presenting the situation analysis across 23 sub-Saharan African countries that they've done related to adolescent treatment and care.
Oh, this one. Sorry, I've got it. Thanks. Great. Good afternoon. Let me just figure out myself over here. How do I go down?
She just needs a bigger.
Enter. It's the wrong way around.
You've got it?
It just went to the last slide.
There you go. So maybe you just need to go.
Do you think you just click?
Oh, this one.
Oh, this one.
Just bear with us. There we go.
Thank you.
That one. Yeah.
Great. Sorry for that. I'm just going to tell you a little bit about the situational analysis that PATA was commissioned to do by WHO in 2015. And it was to look at adolescent treatment and care across sub-Saharan Africa. And this was in preparation of the consolidated guidelines that came out late 2015. 60% of the sample came from facilities within the PATA network. Those were facilities associated to PATA, and the remainder was through partnering NGOs through snowball sampling. A web-based survey was used. 2 versions of the survey were adapted. One was at a higher level with just a shorter number of questions, and then a more in-depth, longer survey as a deep dive were also utilized. The surveys were shared electronically, both in English, Portuguese, and French, and PATA did have to follow up telephonically multiple times to try and secure a good response rate. Okay, I have no idea how to...
You want to move it forward?
Yes.
Okay.
I got it. Okay. Thanks. All in all, 218 health facilities were represented in the sample from 23 countries. Nigeria, Kenya, and South Africa were most represented. 33% were also rurally situated, and collectively all of these facilities cared for over 80,000 adolescents. The key challenge that was identified from the reporting facilities was that of adherence. 39% of the facilities also reported that they had no protocols or guidelines that assisted in determining poor adherence or how to manage poor adherence. Where adherence counseling was in place, what we did see was that much of the attention on the counseling was based on the negative sort of poor effects of not adhering, and there was very little attention placed to the underlying drivers of poor adherence. Peer support was brought up by the majority of facilities as being an effective strategy in supporting adherence, yet many of the facilities did not have the capacity to actually provide the service. Also, interestingly, a high number of facilities reported concerns around mental health issues. Just in terms of data, what we found was 26% of facilities had no working or official definition of adolescence. And the description of an age band ranged anything from 8 to 21. And in 80% of the facilities where treatment outcomes were actually recorded, 80% did not disaggregate this by age at all. In looking at separate service deliveries, 65% of the facilities actually attended to adolescents either together with children or with adults. And out of the 35% that did provide a separate service, most of this service was in relation to a separate day or a specific or a separate time period. Only half reported using any form of guidelines on transition, and while 65% reported integrating sexual and reproductive health services, these services were often limited to just one or two services. Just in closing, I think what the analysis really confirmed, of which I'm sure we all know, and that's what the speakers following me, I'm sure, are going to touch on, is really when working with adolescents, we really need strengthened data management, the use and consistency in use of official definitions in adolescents, indicators, and definitely disaggregated age data. Also for improved protocols and guidelines on poor adherence and retention, and definitely with stronger linkages to psychosocial support services. Further attention and research is needed in terms of peer-led services, not just in adolescents actually delivering the service, but also being involved in designing a service and evaluating the services that they receive. Furthermore, just integrating and increasing access to integrated sexual reproductive health rights, and ensuring that those services are comprehensive. And lastly, just really advancing more deliberate, differentiated models of care and service for adolescents. Thank you very much.
Thank you. The next presentation will be from Cambodia. Dr. Chin.
You have to press this one on the left, yes. Okay, thank you.
Good afternoon. I'm not a doctor, actually. I'm a pharmacist. Before I start my presentation, I would like to thank to my PI who is here, Dr. Yi Si-yan. The study I'm going to talk about will be about factors associated with viral suppression among adolescents living with HIV in Cambodia. A bit about background. We know that if we compare to the adult population, the adolescents treatment, in terms of adherence, is poorer. In terms of viral suppression, it's also lower than adult rate. And also in terms of mortalities, more adolescents living with HIV die of AIDS more than adults. So the study is designed to investigate factors associated with viral suppression among those population. It is a cross-sectional study conducted in August 2016. the group we sample age between 15 to 17 years old. In total, 328 respondents, and of those, 32% receiving their treatment at adult clinics. And in the whole country, we have 39 pediatric sites, but some of those sites are combined with adult clinics. We selected almost 90% of the site, mean that it represent the whole adolescent population in Cambodia. Viral suppression here is defined like less than 1,000 copies per milliliter. For the results, after we control all the confounders, the viral suppression of adolescents are significantly associated with longer duration of their treatment, higher CD4 count of their recent test, and they aware of their that they are on treatment. It's more likely that they are viral suppressed. And if we talk about where they receive treatment, comparing between pediatric and adult clinic, it's found that those who receive treatment at pediatric clinics are more likely to have viral suppression compared to those receiving their treatment at adult clinics. And their knowledge around HIV transmission and also their understanding about AIDS treatment, which is not, there's no cure for treatment, seem to have significant association with their viral suppression. In conclusion, the viral suppression of adolescents living with HIV is around 77%, but it's still lower than the global target, which is 90%. The factors associated with their suppression, including their duration on treatment, the CD4 count, and their knowledge about treatment and also about HIV. So in terms of program improvement, we need to think about their treatment literacy, meaning that they know what they're taking in terms of adherence, side effect management, and also their understanding of transition before they really transition from pediatric care to adult HIV care. That's all for me. Thank you.
Thank you. We'll move on to the next presentation from Kenya by Margaret Mburu from Kemri.
Good afternoon, everyone. My name is Margaret Mburu. I work for Family AIDS Care and Education Services, which is a collaboration between Kemri and UCSF, and provides HIV testing services, care and treatment in Kisumu, Kenya. I'm going to do a presentation on evaluating the implementation and impact of adolescent package of care at health facilities in former Nyanza province, Kenya. In Kenya, more than 400,000 adolescents are currently living with HIV, and almost half of all new HIV infections are among the youth. The adolescent package of care, which I'm going to refer as APOC onwards, was introduced in the country by National AIDS and STI Control Program in 2014, with an aim of providing standardized, targeted adolescent services to this priority population. The objective of this study was to assess use and impact of the adolescent checklist on viral load suppression, family planning uptake, and appointment adherence. Specifically, APOC consisted of facility-level training to providers so that they may understand how to better target their services to adolescents. The checklist captured discussion of services to be offered to adolescents at their clinic visits. Some of these services included reproductive health, mental health assessment, substance abuse assessment, and whether they were actively involved in a youth group. Just to mention a few, we measured the extent to which the checklist was used as a proxy for recommended services outlined in APOC. We observed increased viral load suppression and family planning uptake after scale-up of the APOC. However, these positive outcomes were not associated with increased utilization of the adolescent checklist. Therefore, the checklist was not a good proxy to determine clinical outcomes associated with the APOC rollout. Possible limitations of the study are that there may be factors that determined the positive clinical outcomes that were not associated by the checklist. Secondly, it's possible the checklist does not represent what the providers actually do, because it's usually a clinician and a patient at a time, and there is no one to supervise whether what the clinician marked was actually offered to the adolescent. We require better services for tracking how adolescent services are offered, are provided, like post-visit surveys administered to adolescents. In conclusion, further investigation for additional APOC elements are needed to assess full implementation and impact of APOC on adolescent health outcomes. Our future plans include a pre-post analysis of site-level APOC training to see if the APOC framework introduced in those trainings had an effect on adolescent outcomes. Thank you for listening to me.
Thank you. Our next speaker is Dr. Ashraf Grimwood, who's the CEO of Kethempilo, a nonprofit organization in South Africa. Dr. Ashraf.
Thanks very much. Just like to thank the organizers for inviting us, and also for the chairs for really being diligent in getting the slides sorted. So the topic I'm talking about is the effectiveness and cost effectiveness of community-based support for adolescents. This is a series of talks that we've given, or analysis we've done on patient advocates providing community-based support or psychosocial support for what we call very important patients or vulnerable populations, and young people, adolescents, certainly fall into this category. So the tragic situation in South Africa at the moment is that we have 2,000 young women and girls becoming infected a week. It's an astounding number. We don't seem to be seeing any response, a decline in that, and yet with test all, we're certainly going to be seeing large numbers defaulting. We know that there's an increased attrition rate, and there certainly are poorer outcomes. And unfortunately, the mortality rates amongst adolescents is certainly increasing, despite decreasing in other population groups. And certainly effectiveness and cost-effectiveness evaluations of interventions, improving outcomes certainly are limited. So the aim of this work was to measure the effectiveness and cost-effectiveness of a large community-based support program for adolescents and youth receiving antiretroviral therapy in South Africa. And this is a cohort study including adolescents and youth, initiating antiretroviral therapy at 47 facilities that we, as a not-for-profit organization, have been supporting in South Africa from about 2004 to 2011, looking at age ranges from 10 to 24. The cost-effectiveness methods were expenditure approach used to determine the incremental costs of community-based support to usual care from a provider perspective. The incremental cost-effectiveness ratio is calculated as annual cost per patient loss through death or loss to follow-up. We looked at the numbers, so about 6,706 participants were included, and this equaled about 9,215 person years. About 82% of patients were women, and about 29% were under the age of 19, so between 10 and 19, and a third received community-based adherence support. Two-thirds didn't, and this is based on the fact that we had budget limitations and therefore could only provide adherence support to selected clinics or to clinics where we were allowed to work. So when you look at the loss to follow-up, and I suppose this does talk to many of the other presentations here as representing some of potential solutions to some of the challenges we are facing, there's a 40% improvement or a decrease in loss to follow-up if you have community-based adherence support. And I can go into that a bit more later on during question and answer time. And if you look at the mortality, about a 50% decrease in mortality if you are linked to a community-based adherence support worker, which really should be something policymakers should be looking at, because that certainly does impact on our programs. And many of the donors are not keen on this. So if you look at the costs of the cost and cost effectiveness of community-based support, we're looking at a total cost per patient supported at about $49. And if we're looking at the cost effectiveness ratio or the patient loss averted is about $600, and if you calculate that over 9 years, it's about $67. And for 2 years, it's $776. So in conclusion, community-based adherence support for adolescents and youth receiving antiretroviral therapy was certainly associated with substantially improved patient retention. And we've shown this for both for children as well as for pregnant women. So this strategy does work. It's a low-cost intervention. We use local community workers, and they are trained and they're supported. And they can also move on from a career pathing perspective. Once you get this training, you can certainly do other bits and pieces. And lots of our workers have gone into community auxiliary workers, pharmacist assistants. Cost effectiveness was maximal during the first 2 years of treatment, and certainly policy that supports community-based adherence support for adolescents and youth receiving ART may certainly contribute to reducing AIDS-related mortality in the South African context. Thank you.
Thank you very much, Dr. Ashraf. And our final speaker prior to beginning the discussion is Ms. Anrita Inkahu, who helps lead the HIV prevention program in LVCT Health in Kenya.
So my presentation is going to be on a situation analysis that we did in Kenya. And the purpose was to assess the magnitude of most at-risk population, adolescent, and especially the key population. And we looked at the national, how do I move this downwards? Yeah, so we looked at the national data and the current surveys that had been done in the country, the Kenya Indicator Survey and KDHS. And also we looked at the national data for key population programs and our routine data. And we also tried to assess the policy and the program environment in Kenya, identifying the barriers and the opportunities for HIV and SRH services for the young people. And we did this in 3 counties in Kenya. And the population was between 10 and 19 years. And we had about 108 adolescents. And they represented adolescents who are female adolescents who are sexually exploited and who are in sex work. We also there was also a representation of adolescent boys who are in same-sex relationship, and adolescent boys and girls who are injecting drugs. So what we discovered was that the perspective that were given by these adolescents in terms of access to HIV services, access to HIV and SRH services, their perception to HIV risk was that they see themselves at risk. Some of them have more than one sexual partners, they exchange needles, and they also take alcohol. And I'm not sure whether they have the right presentation, but I'll go on.
No,
I think I have different slides, but I'll still move on.
There you go.
Yeah, so what we found out when we collected data was that they perceived themselves at high risk, but they seem not to have a choice, because the girls who are exploited through sex and those who are in sex work, some of them had children, as I'll show you in the data. Then those who had those who were injecting drugs also used the same syringes and used them several times. And they also had influence of alcohol, and that also increased their risk for HIV. I think I have the wrong presentation, sorry. So in terms of access to HIV and SRH services, what was noted was that it was difficult for them to access HIV and SRH services. They talked about the attitude of the healthcare providers and lack of confidentiality that made it very hard for them to get to public health facility. So they preferred going to private facilities, though they said that the cost was a little bit high for them to be able to access. So generally, what I would say in our conclusion is that I think we do not have enough data, and our national data is not segregated to be able to identify this population who are at high risk. And we have also confirmed that these adolescents who are having same-sex relationships exist, and it's very silent, and there's no one who is able to address that. So we are recommending that in the next surveys that will be done in Kenya, this is an area that we need to be able to collect the data so that we can be able to have some very good action on this. Then the other thing that we noted is that our policy also is silent around these adolescents who are key population. So it's a little bit silent. So even when you go to the health workers, the interventions that they have are either for key population or for general youth, and it's difficult for them to know what to give to these young boys who are having anal sex. There are no ready-made interventions, and the skills also for the health workers. They do not know how to handle these young people. Thank you. And really sorry, I think I got the wrong slides. Okay.
Thank you very much. And so we do have 2 microphones here in the room. If people have questions, if you could start queuing up. But we've had 2 situational analyses, 2 surveys, where we can see that there's really insufficient resources to support adolescent clinical care, for support for adherence, retention, the cascade. But then we just heard about not only that, but we are really failing our young key populations. Young MSM, you were sharing about about how needles have been shared multiple times, and that's certainly a big concern and is completely unnecessary when appropriate harm reduction materials are procured by governments. We also heard from Cambodia, where the point that being in the adult clinic was associated with not having viral suppression. And so where is the breakdown in the transition between adolescent to adult care, and then trying to use a checklist to try to improve rates of viral suppression. But it's not just creating the tool, it's figuring out how to deliver those services to make sure that that tool is really going to be useful. And two other talks, the one from Dr. Larissa, which gave a very different kind of perspective than I think we're used to seeing, looking at how you have an economic perspective or rationale with regards to having more money means either more sex or different kinds of sex or different kinds of risk behavior. And then what we heard from Dr. Ashraf about how community-based adherence support can really work, and yet you said donors are not interested in this, and yet I think it was, what, $50, $49 per patient per year, and we are in fact investing many, many, many millions of dollars in trying to collect data to tell us that our adherence is not doing well, and I'm a big supporter of investing in quality data, and yet I also wonder what's the trade-off. If it costs $50 to improve adherence, I want that adherence to be improved. So why don't we start out and see who we have questions from. Please feel free to come up. I know it's a tight room. You can get out of your chairs, but we have the first comment over here, and then we will have the second here, and then we have Nancy, and then over there. Okay, over here, please.
Over here.
Oh, she's got a microphone first. Go ahead.
Thank you. I'm Ashley Grosso from Public Health Solutions. I was wondering for the panel, and particularly regarding key populations, what challenges you faced with ethics committees in getting parental consent or waivers for inclusion in these studies.
Thank you. Ms. Ikaku? Do you want to respond to that? How did you get consent for including key populations in your survey?
Yeah, thank you for that question. This was a national survey, so we also got ethical approval through the relevant bodies in the country, and it was also done with us and the National HIV and STI program.
Okay, you can go ahead.
Thank you. Good afternoon. My name is Tinta Nalubamba from SFH in Zambia. My question is to, is it Chim, the presenter from Cambodia? I saw that the age range for the study participants was quite narrow, 15 to 17, and one of the variables you're looking at is the fact that being in an adolescent clinic or pediatric clinic made a difference. So I was wondering if you'd actually see a difference in result if you had extended that age range to include some of the older adolescents beyond 17 years.
Yeah, good question. Do you want to answer that, Chef?
Yeah. Actually, the study was aimed at seeing the transition of pediatric adolescent from pediatric care to adult clinics. So in Cambodia, in theory, transition age should be started from 14 years old, but in practice, we've got a problem like some adolescents with an transition at the age of 16 or 17, or some might be transitioned up to 18 or 19. So we need to work out more like how to make sure that they're ready for transition from pediatric care to adults. Did I answer to your question?
Okay, Nancy?
Thank you. So for Dr. Lessing, I want you mentioned briefly that there was price sensitivity to both condom use and testing, and I was wondering if you can comment on that. Like, is it that you get more without condoms, and how did testing figure into it? And similarly, sorry.
Speak into your mic.
Oh.
Yes, I can't hear you.
Should I repeat that? And then my second question was, what kind of text would you send to mitigate an issue that had to do with scarcity? And then really quick for Dr. Grimwood, could you characterize the nature of your community-based support, and also how homogeneous was it in terms of quality and such? What did you actually do?
So Melissa first.
Sure. I didn't quite catch your first question, but I can answer your second.
You said that price was sensitive to condoms and testing. So what did you mean by that?
Sure. So in terms of the first question, in terms of price sensitivity, young girls in particular talked about wanting to, or being curious about using female condoms and how expensive they were relative to male condoms. And in that sense, they were price sensitive to...
Could you repeat that? I'm so sorry.
Sure. So to answer your first question about price sensitivity, this really came out among young girls who mentioned that most of them carried male condoms but were curious about female condoms, but they were so much more expensive. And so the conclusion then was being price sensitive to female condoms in particular. When it comes to HIV testing, it's often free. However, in terms of sensitivity, the indirect costs, so costs for meals away from home or the settlement, and also lost income opportunity for young boys in particular. So your second question related to the...
Scarcity and sending a text
Exactly. Exactly. So I had suggested in terms of, so what do we do now? What could be some possible interventions? So we're actually investigating this within the U.S. context about how to send text messages. So on the one hand, we've enrolled about these are not youth living in urban slums, but they're homeless young adults in the U.S. So it's a similar context. So on the one hand, we're sending daily to weekly text messages to assess their economic status, so whether or not they have housing or sufficient food or an income. And then based on that, we're also then developing text messages that try to encourage them to think about deferred gratification, understanding risk relative to the future versus, present versus the future. Really just trying to shift their thinking in terms of not making immediate decisions based on their current economic needs. So it's about, what I like about behavioral economics is it really forces you to think about the psychological impact and how people think about sexual decisions. So those text messages are really geared towards using language from, so in Baltimore we're actually doing some qualitative work to incorporate their own language into the recommendations about how to make decisions that better compensate for that sort of burden.
Great. Ashraf, do you want to answer the question on community outreach?
Yeah, sure. Thanks very much. I think it's a good question. So basically, all our community co-workers have to meet criteria, certain criteria. They've got to have 12 years of education. They've got to come from the local community. They've got to be able to communicate in the local dialect. They have to have shown some community responsibility and are actually employed. So these are not volunteers. They're paid. And they are given the same rights as everybody else in the organization. They also then have weekly debriefing sessions, so 1 day a week they work in the clinic, and that helps with data collection, data monitoring, data quality evaluation. And then they're also supervised. So the critical thing of community outreach work is that you just can't expect community workers to work on their own unsupervised, especially where they are so-called lay people who have only had maybe 3 or 4 weeks of training. And then we also repeat the training, etc. And they've been really fantastic in managing the various categories of patients, especially your vulnerable with adolescents, and then also your pregnant mums, and getting them connected, getting them linked, because that's critical, really is critical.
Thank you very much. My name is Eva. Margaret, Larissa, and Anarita. You have worked with young people and adolescents and have actually engaged them in lots of discussions regarding their health and actually outcomes, especially with regard to the adolescent package of care, the urban slums program, and the key populations. I'm curious about what did the adolescents say they wanted that would work for them so that they could have the best health outcomes with regard to their situation. Beyond just what we as healthcare providers or managers thought was good for them. So have we been able to incorporate some of these things in the interventions that we are having? And what's the way forward? I'm very curious about that. Thank you.
I think I could go first and say that for us, we are trying to work together to develop some interventions because people have denied that adolescent key population do not exist. So no one talks about it. And even when we talk about it, no one knows how to go about it. So what we are doing, we've had focus group discussions with them. When they go to access services to the key population, usual dices, they are not able to be given access to that. So they cannot even go to the integrated services in the facilities because of stigma and even the confusion of the health workers of what do we give them? Do we give them youth interventions or what do we offer? So what we are doing is that we are putting together, because it's a situation analysis that was done in the country. So we are trying to move this forward by putting together some interventions. We've done focus group discussions and we want to start offering this in our regular sites, and then we'll be able to inform the rest of the country. We are also going to focus on our policy review, because the current policy key population, our current guideline in Kenya only speaks to the adult key population, and all the interventions are for adult key population. So we are also trying to advocate for review.
Thank you. We have 3 more questions. In the interest of time, if you can all ask your questions, keep them very brief, and then we'll get our panel to give the final comments.
Okay, thank you. Thank you everyone for your for the good presentations. My name is Millicent from the Desmond Tutu HIV Foundation in Cape Town. And my question goes to Colab Chim. So literature seems to suggest that the longer, especially for adolescents, the longer they are on treatment, the more they are likely not to adhere to treatment and therefore not virally suppressed. But your findings seem to suggest suggest the opposite. Now my question is, were there specific programs that you held with these youth? And if so, what sort of programs did you hold? Thank you.
Next question.
My question's to Larissa, but thank you all very much for an interesting panel. My name is Constance Mackworth-Young from the London School of Hygiene and Tropical Medicine and Zambart. And I was really interested to hear about your economic approach to the sexual decisions of adolescents and young people. And often the sexual experiences of adolescent girls in particular are often framed in terms of vulnerable young women and predatory older men. And I would just be interested in your thoughts as to how you think your approach and your research of looking at kind of more rational explanations for sexual decision-making from an economic framework, whether that supports that, or whether that counters that, or how that kind of fits into that framework of vulnerable and predatory.
Thank you. Yes?
Yeah, thank you very much. These are the questions for Ashraf. So I'm wondering how long was the time horizon when you analyzing the impact of this community-based adherence support. Second, you mentioned the first 2 years are cost-effective. I want to ask you, what was your threshold you used to define cost-effective, and why you choose that threshold? The third is, I see you have data from the first 2 to 6 years or 7 years or under. I did not see the slides very clearly. I'm wondering, what is the proper time horizon to assess cost effectiveness of such a program?
Thank you. The last question.
Great. Thank you all for a great panel. I'm nonetheless the Pilgrim. I'm from the Population Council, and my question goes to Enrita, if I'm pronouncing that correctly. I was struck that your findings are very similar to our findings in adult population KPs in Zambia. And one of the things that they mentioned was that you mentioned private providers that their preference was for, but they also mentioned community-based providers. And I was curious about your thinking around private-public community-based partnerships in serving key populations.
Okay, so we'll just go through the questions. The first one is around the length, the duration of treatment and impact on virus suppression, and what's your explanation for that, knowing that retention in care is problematic in the long term in adolescents?
Thank you for the question. We actually have, in our national program, a package of services to support adolescents and, support children and also adolescents. In terms of disclosure, like they should know their status and who will be their supporter during their disclosure. So this is very important and critical point. And in our study, found that they find service provider at their pediatric care services are very helpful, and they are the first person who they disclose their HIV status. They feel comfortable to talk to their pediatric service providers, and that's the point that. They've been on when they on treatment for a long time, and we also support them during their transition. we have also, services at pediatric and adults to make sure that they prepare themselves for transitioning to adult clinics. For example, like the pediatric doctors should visit the adult doctors when they prepare their adolescent for transition. So I think that those factors contribute to the viral suppression and adherence to treatment for adolescents.
So we have a question for Jenning on the economic approach, and then Ashraf, if you can answer the question on your analysis. And the last question goes to Anrita around the key POPs findings. So if you can just speak for 2 minutes each, and then we'll conclude.
Okay, I'm next. So I will answer both the second question and then the first question. So to answer your question, yes, this is certainly rational, and I think that's what I was trying to say earlier, and thanks for the opportunity to share more. So in terms of boys, the sexual interest and curiosity in terms of when you have additional financial resources and purchasing more goods or services because of that is completely rational economic behavior. So the idea of having more sexual partners when they have more income is completely normal and rational. And for girls, a lot of the comments about needing to earn income and not having safe working environments, even if it's working at someone else's home or on their farm, being exposed to sexual advances or even rape through efforts to earn income, which is also a rational behavior to seek ways to earn money. And so in terms of interventions proposed by youth, so some of it are a lot of the comments related around employment, as you can imagine, not just in terms of jobs in the immediate future, but also training and education, and being able to, both for young boys and girls, being able to earn income in a way that was consistent with their skills, but also in a safe way, particularly for girls. And then for boys, there's this interesting finding about being counseled or supported in ways to better invest in themselves, whether it be through saving. So this idea of compensating for scarce periods, whether it be financial scarcity or not having enough sex because they weren't able to get girls, wanting some support around how to save and think about the future. There's also a few comments about not being able to invest in one sexual partner because they didn't have sufficient resources in terms of settling down and having a family. That required more resources than they could really manage at the time. So I think in terms of a summary, I would certainly say employment, savings, thinking about self-investment and economic empowerment, both for girls and boys, and particularly for boys, helping them think through, once they have additional resources, how to use those resources in a way that doesn't increase their risk for acquiring HIV or transmitting it to others.
Okay, thank you. And it's good to, I think I agree with your recommendations that it's important to explore public-private partnership, but in Kenya, we have two modalities on how we offer the key population programming for free standalone sites that are sometimes referred to as DICEs, and also Kenya is moving into integrated key population program services, and that is more sustainable. And what we've seen for already the public health facilities that are integrating key population service delivery, we've seen very great successes. So the idea here is to have a very clear package of service that is supported by policy and also the capacity building of the health providers, and then it's easy to offer that intervention. Thank you.
Okay, thanks. I'm going to try and answer your question. So we looked at 5 years data, and I think you could do 3 years as well. So WHO has defined cost effectiveness as less than 3 times your GDP per capita, using the cost per daily averted, and highly cost effective as less than 1 GDP. Now you have to remember that South Africa's GDP at the time of this work was $7,500 per capita. We are now at 5,700. So, and that's kind of how we looked at the cost effectiveness in the sense of this investment. Thanks.
I think we've come to the end of the session, and thank you for staying on. Just to conclude, we've heard very diverse issues that are affecting this population. And so I think the critical question is, as we move ahead with the ending AIDS by 2030 and the targets that we've set for 2020, within public health programs, I think what's come clear with this discussion is within those public health programs, we do need differentiated support for this population. And I think the conversation around which populations need what type of services, I think is becoming very clear, and it's interesting that adolescents are being included in that dialogue, and I know that WHO will be looking at this in terms of what we come up as guidance. The differentiated care comes with a cost, and I think Ashraf's work, putting a cost value on some of this support, I think is important, and we need to do more of this work to be able to convince policymakers and donors that this work is important and we can achieve impact and results.
And this is yet again another standing room only session on adolescents. We had one yesterday morning. Thank you all so much. We want to encourage you to emphasize the importance of this topic in your feedback. I'm sure you'll be getting emails in the app asking you to do those kinds of surveys. The IAS really does look at that feedback in determining how many sessions to allocate to different topic areas. And this was particularly unique because we had the clinical side, we had operations side, we had tool development, community-based interventions, and economic-related analyses. And it's not easy to put this kind of content in an oral abstract session, which is why poster discussions are a very good format for this. So thank you all very much for your support, and join me in thanking all of our panelists today.